왔어? 아, 하면 되나요? 마스크 하면 돼요? 아, 예, 예. 행사에 앞서 잠시 안내 말씀드리겠습니다. 잠시 후 11시부터 국정과제 대상국 중심 개발협력 국제 세미나가 시작됩니다. 참석자 여러분께서는 원활한 행사 진행을 위하여 자리에 착석하여 주시기 바랍니다. 가지고 계신 휴대폰은 진동 모드나 모음으로 변경하여 주시기 바랍니다. 아울러 코로나가 심각한 상황이니 행사 내내 마스크를 착용하여 주시기 바랍니다. 오늘 세미나는 한국어와 영어로 동시 통역이 진행됩니다. 통역이 필요하신 분께서는 통역 수신기의 채널을 한국어는 5번, 영어는 6번으로 맞춰주시기 바랍니다. 또한 오늘 행사는 유튜브를 통해 실시간으로 방송될 예정입니다. 다시 한번 안내드립니다. 곧 국정과제 대상국 중심 개발협력 국제 세미나가 시작되오니 휴대폰은 진동 모드나 모음으로 변경하여 주시고 마스크를 반드시 착용하여 주시기 바랍니다. 통역 수신기는 한국어는 5번, 영어는 6번입니다. 더 해야 되나요? 목소리 체크만 하시면 되죠? 그냥 이 정도 톤으로 그냥 하면 될 것 같아요. 네. 안녕하십니까? 지금부터 국정과제 대상국 중심 개발협력 국제 세미나를 시작하겠습니다.
비용 없어. IPT는 그 설정을 해야 되는데 여기가 리셋을 맨날 할 때마다 빠지는 거라서. 하나, 둘, 셋. 하나, 둘. 하나, 둘, 셋. 하나, 둘, 셋. 네. 됐죠?
Recording in progress.
Hi, Ms. Suji. Hi, hello, Dr. Gu from Mukti. Can you turn on your camera?
Hello, Miss Ayong.
Yes, hi.
The meeting will begin in 9 p.m. sharply. Okay.
Yes, we wanted to just check the position, camera position.
Oh, okay. But Professor Mukti has not arrived. So maybe we can try with Mr. Hendrawan.
With yours?
Mr. Hendrawan. Mr. Doni Hendrawan.
Hedrawan, okay.
Yes, the speaker.
Then, Mr. Hedrawan, can you turn on your camera on? Hello, Mr. Hedrawan, can you turn on your camera on?
Hi, Miss. Can you go to the next slide, please? So we can check. Okay, go again.
그분 카메라 켜셨나요?
Okay, next, please. Okay. Next, please. All right. Okay, I think it's perfect. Very good. Thank you. Perfect.
Hi, Mr. 헤드라완 씨. 지금 한국말로 제가 얘기해야지 통역으로 좀 통역 채널을 맞춰야 될 것 같아서.
Mr. Hedron, could you please turn on your video?
Okay. Sorry, I guess. Okay. Is it okay? My video?
영어 잘 들리시는 거죠?
Could you please turn on your camera?
I already turned on my camera. Can you see it?
Yes.
Is it clear?
Yes, it is very clear. Thank you.
Okay, thank you.
Good morning, Mrs. Ayong. Can you hear my voice? Good morning.
네, 안녕하세요.
Hello, good morning.
안녕하세요. Yeah. This is the mic of Professor Gufron. I just want to test that the mic is already working. Thank you.
제 한국말이 들리시나요?
Can you hear our Korean?
Yes, you can hear clearly.
제 말이 한국말로 들리시면 if you hear my voice in Korean 바꾸셔야 합니다.
Can you hear Korean? Then you have to change it to the English channel. You have to listen to the English channel only.
Hear English.
인도네시아 패널리스트 분들은 카메라를 모두
So please turn on the camera. I'm speaking to all the Indonesian panelists. Please turn on your camera on the computer.
세션 성패로
So please
여러-
keep your camera on, and then we will start the session from 11 o'clock.
우리 여기 있어. 이거는 저기 원장 저기 얘 가져도 돼. 네, 행사에 앞서 잠시 안내
Before
말씀드리겠습니다.
I begin with the seminar, I would like to make a short announcement. Around 11 o'clock, we will begin the International Development Cooperation Seminar. I would like to ask all the participants to be seated. And please turn your smartphones to silent mode or vibration mode. And due to the COVID pandemic, I would like to ask all the participants to keep your face masks on throughout the seminar. Simultaneous interpretation will be provided into English and Korean. If you need interpretation, please set your receivers to number 5 for Korean and number 6 for English. The seminar will be live streamed via YouTube. Let me briefly introduce today's agenda. We will first begin by listening to the opening remarks from Korea and the welcoming remarks from Indonesia. Then we will move on to taking a commemorative photo taking between Korea and Indonesia, marking the MOU signing. And all the panelists from Korea and Indonesia will take a group photo afterwards. This will be followed by the first session's presentations and discussions. That would close the first session of today's seminar, and the second session will proceed in the same manner. We will begin at 11 sharp. Good morning. We will now begin with the International Development Cooperation Seminar. My name is Mae-suk Kim, the manager of the Global Cooperation Team of NHIS, the MC for today's seminar. Under the global pandemic, the role of healthcare insurance has been becoming ever more important. This seminar will be a meaningful event to discuss our current systems and future directions, and also strengthen international cooperation. Before I begin, let me introduce our guests of honor. Please welcome them with a big round of applause. First of all, the offline participants in Korea. Head of the Health Insurance Research Institute of NHIS, Mr. Hae-jung Lee. Professor Chang Bae-jeon from Usong University, who is the moderator for the first session. Let me now move on to our panelists. Professor Deok-kook Kim of the School of Nursing of Kacheon University. Kyung-yeol Kong, Development Cooperation Council member of NHIS. Mr. Won-hoon Kim, a member of the Development Cooperation Council of NHIS. Director General Sang Baek-kang of Global Cooperation of NHIS. Mr. Kyurak Park, the Head of Development and Cooperation Team of NHIS. Let me now move on to our online participants. First of all, President Dr. Ali Gufran Mukti of BPJS Kesehatan of Indonesia. And Deputy Director of Information and Data Management, Mr. Donny Hendrawan of BPJS Kesehatan, who will give a presentation today. We also have a lot of distinguished experts from BPJS Kesehatan. My apologies for not being able to introduce everyone in the interest of time. Now, let me introduce today's seminar. We have two different sessions today. In session 1, we are going to listen to opening and welcoming remarks and also take a photo commemorating the signing of MOU with Indonesia. We're also going to talk about the issue of strengthening cooperation between Korea and Indonesia for sustainable UHC. We will listen to presentations and have a discussion. And in the second session, we're going to talk about achieving UHC by improving healthcare services in countries experiencing system changes, including Kazakhstan, Georgia, and Moldova. Now let us officially begin with the International Seminar on Development Cooperation. First of all, let us listen to the opening remarks from Dr. Hae-jung Lee, the head of Health Insurance Research Institute. A big hand, please. It's a pleasure to meet with you. My name is Hae-jung Lee, the head of the Health Insurance Research Institute of NHIS. First of all, I would like to thank Dr. Ali Gufran Mukti of BPJS Kesehatan of Indonesia, Dr. Nino Moroshikina of the World Bank. Excuse me. Is everything all right now? There was a technical glitch. I apologize. Dr. Ali Gufran Mukti of BPJS Kesehatan of Indonesia, Dr. Nina Moroshkina of the World Bank, speakers, and participants, let me extend my warmest welcome to all of you. It is a great pleasure to be holding the International Development Cooperation Seminar to share experiences and strengthen cooperation under the goal of improving the healthcare system and advancing universal healthcare for our countries. Korea adopted the insurance system in 1977. 12 years later, in 1989, we achieved universal healthcare for all citizens. In 2008, we introduced the long-term care insurance for the elderly. As such, we've been striving to enhance the health and quality of lives of Koreans. Thanks to UHC, key healthcare indicators such as average life expectancy and infant mortality hovers above the OECD average, demonstrating a substantial improvement in public health. Especially, Korea's advanced information and communication technology has been applied to the health insurance system to utilize big data in managing public health and care facility information, and in developing the public health and safety response system and national health insurance policies. Despite the global pandemic, based on our health insurance system and ICT, Korea has been known to efficiently control COVID-19 and manage confirmed cases. The role of health insurance has become all the more important under the circumstances. I heard Indonesia, Kazakhstan, Georgia, and Moldova have all been striving to improve and develop the health insurance system in their countries. Korea still faces the challenge of an aging population and sustainability. I hope we could learn from each other's systems and challenges to gain insight for advancing the health insurance system and take this opportunity to reinforce our cooperation in the future. Let me thank all speakers and experts who've agreed to share your insights in the seminar despite your busy schedules, and wish for a fun and productive seminar today. Thank you very much. Thank you, Doctor, for the opening remarks. Now we will move on to listening to the welcoming remarks by Dr. Ali Gufran Mukti, the President of BPJS Kesehatan. A big hand, please.
Honorable Mr. He Jong Lee, Head of the National Health Research Institute, National Health Insurance Service of Korea, Mr. Chang Bae Jeon from Wasong University, Mr. Sang Baek Chris Kang, Director General of Global Cooperation, National Health Insurance Service Korea, and the same time also as the Vice Chair of the TC Health, ISA, representative from World Bank, and also representative from Moldova, Georgia, and other countries. Distinguished panelists, speakers, ladies and gentlemen, a very good morning to all of you. Firstly, I wish to thank my colleagues from National Health Insurance Service of Korea for hosting a joint international webinar with the theme Strengthening Universal Healthcare Coverage and Future Direction in Healthcare System. It is my privilege to give an opening remarks in the joint webinar today, and hoping that we are staying safe and healthy during this tough period of time in the era of COVID-19 pandemic. As we all know, that the process cooperation extension of Memorandum of Understanding or MOU between BPJS Kesehatan Indonesia and NHIS Korea has successfully signed by both of the parties in virtual format in the time of pandemic COVID-19. The cooperation between BPJS Kesehatan and NHIS has been developed in 4 years and implemented successfully with various joint projects and research. Considering the mutual interests and goals of both organizations, the objectives of the MOU is to establish cooperation framework between the parties to promote mutually beneficial cooperation in the field of health insurance system. BPJS Kesehatan and NHIS shall develop the cooperation in the following areas: strategic purchasing. I think it is very important given that the resources is always limited and scarce. So how we can purchase efficient and effectively. Revenue collection, of course, it is not easy things, especially where in the country that informal sector is still dominant. Risk pooling, then financial risk management and data-driven healthcare system. BPJS Kesehatan and HIS agree to implement the areas of cooperation through the following forms: sharing of expertise, information, and best practices, organizing joint seminars, conferences, workshops, and other professional meetings, training, internship, and exchange program for professional, and any other forms of cooperation as mutually agreed in writing by both organizations. As the part of the implementation of the MOU, today we are hosting a joint international webinar as a starting point for the knowledge exchanges between two organizations and other parties. The international webinar also will be attended by neighboring countries such as Kazakhstan, Moldova, Georgia. Now, please allow me to deliver the overview of the National Social Security Program in Indonesia. According to the Indonesian law of the National Social Security System, the law number 24 in the year 2004, BPJS Kesehatan is mandated to manage health social security program for all Indonesian citizens. Until June 30, 2021, the membership has reached 224.9 million, or 83% of the total population of Indonesia. As you know that Indonesia is the fourth most populous country in the world. And Indonesia has more than 17,000 islands, which adds the complexity and challenges to achieve accomplishment in COVID's expansion. During the pandemic, just like any other countries, Indonesia also faced similar challenges due to COVID-19, especially in formal sectors, as well as in the informal sectors membership segmentation. The common challenges to optimize Social Security health program coverage are membership of informal sectors, the ability to pay the premium is still relatively low due to economic factors, especially during the pandemic. The other challenge is the middle and upper class people who sometimes refuse to register to become health social security members because they already have their own or maybe their private insurance. Number two, membership of the formal sectors. The increasing of unemployment affected by COVID-19 pandemic, so that private company deactivate the employee membership in JKN. Then number three, data validation still becomes the main challenge, so that it is important to integrate the data across ministries, agencies, and also other type of some social security like BPJS, other BPJS. Then policy, number four, policy and regulation issues. Law enforcement in public services has not been fully implemented, especially for the informal sectors. We all strive hard to end this pandemic and keep doing our best to protect Indonesians with health social security, to make sure that financial protection is available for all Indonesians. To answer the challenges in achieving universal health coverage, there are several national strategies. First, National Medium-Term Development Plan 2024 goal already determined 98% of the population covered in the national health insurance. Of course, it is not easily task and target because many challenges. Number two, premium subsidy from government to the informal sector. Lowest premium plan starting July 2020. Number three, community funding. We are trying to have innovation of type of donation program for informal sectors. Number four, optimizing the recruitment of private companies that does not affected by COVID-19. Number five, optimizing local government role in increasing JKN coverage. As we know that in Indonesia, more than 35 million people are paid by local government to be included as the member of JKN scheme. Number six, development of monitoring and evaluation system for the implementation of JKN through information technology, especially the Industrial Revolution 4 products. Then seven, expansion of online and offline based registration channels. We are working together with bank and other type of agencies. Number eight, strengthen the coordination across ministries, agencies, and local governments and policy and regulation. Therefore, I'm hoping today's seminar will also give us an overview of the role of social security organization from all around countries, especially our neighboring countries, toward universal health coverage and overcoming the COVID-19 pandemic. That is all, and thank you. Have an amazing webinar to all of our audiences. Stay safe and healthy. Thank you very much.
Thank you for the great remarks, Dr. Gufran Mukti. Next, we are going to take a photo commemorating the MOU signed between Korea and Indonesia. I would like to ask Dr. Hae-jung Lee and President Mukti to hold the MOU documents and look at the camera for the photo. Okay, we have taken the photo. Thank you. And next, we are going to take a photo of all the panelists from Korea and Indonesia all together. Please turn on your cameras and please look at the camera. Thank you very much. Now this will officially close the opening ceremony. Thank you for listening to the ceremony, and we will now begin with session 1 that will be moderated by Professor Chang-bae Chun.
Let me introduce the Professor Chun Chang-bae. He is the professor in the Healthcare Management Department of the Wusong University, and he worked for NHIS for 25 years. And he is the Director General of the Development Corporation Division. in the foundation, and he is in charge of many studies, including the healthcare insurance system, policy, and the policy evaluation.
Okay. Thank you. Good morning, ladies and gentlemen. Annyeong hasimnika. Assalamualaikum warahmatullahi wabarakatuh. I wish you are all in the good health and safe despite of the pandemics that happen right now. But before that, I would like to inform you that why I opened my mouth since in Jakarta right now is in lockdown. So I make this presentation back from my home. So I think it's safe for me to open my mouth. So my name is Donny, and I'm working as Deputy Director of Data Information Management for Indonesia Social Security Body for Health, or BPJS, under Mr. Edwin Aristiawan, our Director of Information Technology. Actually, Pak Edwin himself wanted to give this presentation, but unfortunately, he cannot make it. So he sent you all his respect and personal warm greetings, and hope that our partnership will increase our capacity and capability to reach effective universal healthcare coverage. I also want to send my greetings and respect to the Honorable Professor Ali Guzman, PhD, our President Directors, Dr. Muni Harno, our Director of Cooperation, Dr. Han Jung Lee, Head of NHIS Research, Director General of Global Cooperation Department from NHIS, Mr. Sang Baik Kriskang. I'm sorry if I'm not saying your name correctly, and other representatives that I cannot name one by one. Thank you very much for giving us opportunity to share our experience in this webinar. And last but not least, ISA representative, the moderator for the presentation, Professor Chang Bai-chun. Thank you very much. All the participants from Indonesia, South Korea, Kazakhstan, Georgia, and Moldova, and also all committee members that have been working hard to serve these webinars. Next slide, please. Next slide, please. Okay, thank you. Ladies and gentlemen, there are three issues that I would like to highlight in this session. First, I will share to you a brief introduction about our social security health program, or we name it GKN, current progress such as the growth of participants, distribution of participant age and gender, and development of our healthcare provider networks. On the second issue, I will share about Indonesia healthcare services ecosystem and the role of big data in enhancing the data-driven healthcare. And on the last part, I will conclude of what we have learned and experienced, especially the role of IT as enablers, drivers, and accelerators towards a data-driven healthcare. Next slide, please. So here in this slide, you can see Indonesia has implemented the GKN program since 2014. Until the beginning of July 2021, the total member of JKM program has reached 225 million people, or 83% of total populations. As you can see in the graph on the left side, most of the JKM member, which is around 43%, is funded by central governments, known as aid recipient member. The amount of contribution is not too many, just like $2.9 per member per month. So you can see in the yellow sections, which are covered, 16% of total member are also the aid recipient member, but they are funded by local governments with the same amount of contribution. Then the green portion represent the formal sector, which covered around 25% from total member, and the amount of their contribution is calculated based on the percentage of the salary. 4% paid by employer, and 1% is paid by employee. The last is the red portion, represent the informal sector that covered around 16% from total member. They actually funded themselves, and the amount of contribution based on their choice, considering their ability to pay. The amount of contribution consists of three categories. From first class, which were around $11.3 per member per month. Second class, which was $7.8 per member per month. And the third class, which were $2.9 per member per month. But you must all know that the different price from contribution does not relate to the benefit they will receive, but it's only related to the inpatient room where they will stay when they need hospital care. So basically, there's no differentiation in benefit across all segments or contribution class. The distribution of the participant based on gender consists of 50.80% men and 49.17% women. Based on the proportion of age group, most of our members are in their productive age, both on men and women. The number of contracted health facility providers is totally around 26.7 thousand, which consists of 22.7 thousand primary care providers, around 2.6 thousand hospital, and the rest is for pharmacy and optic, is about 1.4 thousand. This total of providers number increases each year, with a portion of privately owned providers more significant than the government or state-owned providers. All these contracted healthcare providers have been selected through credentialing process or re-credentialing each year to ensure their capacity and capability meet the requirement national quality standard. This entire health facility service serves all registered participants and is spread across all regions in Indonesia. Next slide, please. So, next slide, we can see that Indonesia healthcare system is basically a three-tier system. It consists of primary care, who act as a gatekeeper, secondary care, which consists of, we call it type D and type C hospital, and tertiary care consists of type B and A hospital. As a gatekeeper, as you know, maybe, primary care have an active role to ensure whether the patient needs to be referred to specialist treatment or not. Also, primary care conduct as a coordinator for diabetes and hypertension patients. They actively increase patient knowledge about the disease, their compliance for treatment, organizing them to conduct healthy lifestyle, giving them feedback about their condition, and communicate with specialists in hospital to ensure the treatment continue. Also, there are 144 diseases considered as primary care core competencies, which they must comprehensively treat. This role actually reflects the four pillars of primary care, which are first, contact, longitudinal, continuity, and comprehensive, as stated by legendary expert of primary care, the late Dr. Barbara Starfield. The payment system at the primary care level, we use capitation model and scheduled fee for service or per diem for inpatient treatment in primary care. Also, we pay a negotiated price to pay drug services for stable chronic disease patient. So you can see the second tier is, like I mentioned before, is type B and C hospital. That why they call type B and C hospital? It means that they carries out at least 4 basic specialist services, which are pediatric, surgery, internist, and obstetrician, and have certain number of beds. Patient is not allowed to directly go to the hospital except they are in emergency situation. Access to the hospital is mandatory to go through the referral of primary care. And the top tier is, or the third tier is a type B and A hospital, which deliver subspecialists and usually conduct as a top referral in the regions. Basically, we divide Indonesia in several regions, and they have an extensive range of subspecialist treatment, extensive number of beds, and also capability to manage more complex diagnosis or treatment. And as for hospital services, we're using the CBG payment or DRG models, both for outpatient and inpatient services. They also negotiated fee for service payment for special drug payment like chemotherapy or drugs for hemophilia. And for the benefit package, the JKN program covered extensive comprehensive benefit range from health promotion, health prevention, disease treatment, and rehabilitation treatment. So this is what actually the brief introduction of JKN healthcare services. Next slide, please. So I would like to move to show you all how the JKN healthcare ecosystem, where we can see how all IT systems that facilitate enabling patient flow have been integrated into the JKN integrated care cloud system and data platform. So basically, it started when the patient used the mobile JKN application to get their query numbers and integrate their data into the primary care system. So every member can do it by himself or herself using their mobile phone. And so when as soon as they enter the data, so the primary care doesn't have the data will integrate to their primary care system. So when they appear in the primary care facility, the primary care doesn't have to manually enter the credentials again and again, like membership number, name, age, etc. And in primary care providers, health officers will verify the membership status of the patient. And then they will create the health data recording, viewing the history of patient data who have visited the entire BPJS Kesehatan provider network, and also refer them to the hospital through electronic referral system, whether it is necessary. When the patient admitted to the hospital, the admission system will also automatically display the data of the participants since they have been entered in the primary care. Again, the health officer will record diagnosis and health procedures the patient needed or have. But to ensure patient eligibility, especially in extensive treatment like hemodialysis, we implement a fingerprints recognition. But due to the pandemic situation, right now we are working, and in the near time, we will implement face recognition to improve convenience, minimizing infection risk, and ensuring data security. And I would like to say that the IT integration is not only implemented in primary care and hospital sectors. There are other integration going in other sectors, such as integration with the traffic accident fund for patients who have traffic accident. Since the traffic accident, the patient who suffered traffic accident is firstly funded by other governments funded body. The second is the online pharmacy systems. The third is digital claim process from primary care hospitals. So right now, we implement a paperless claim process, and then integration with banking system to speed up payment process and ensuring hospital cash flow sustainability. And we have what we call the Health Facilities Information System, or HFAS, which used to record and update health facilities improved, such as number of health workers, medical equipment, hospital license, number of available beds, etc. Also, the FHIS can be used by health facility to submit their proposal whether they want to join the selected provider network. So they can see the process. And also, we conduct teleconsultation and interaction with physician at the primary care in real time through mobile JKN application. So the entire system at each point is integrated on a single platform that managed and operated by BPJS Kesehatan. Next slide, please. So in this slide, all data that have been collected to the JKN integrated system will be processed and analyzed following governance and regulations, especially regarding managing data and information security. And then the data is analyzed and visualized to various stakeholders, such as we delivered analysis to the central government and local governments in the form of dashboard visualization. So they can see trends, demographics, and disease utilization according to the region characteristics. This is expected to encourage local governments to develop strategies and policies supported by data as a basis for supporting JKN implementation. And for academics and researchers, we regularly prepare a sample of data that represent the population data. The data is offered the individuals, which has been masked or encrypted to ensure data security. The data increases every year. Right now, it's nearly reached 13 million rows of data that academics can process. We encourage the creation of policies from various studies to improve the JKN program implementation. And for our healthcare providers, we supply the data analytics to give them feedbacks about their performance. I think it's very important because this feedback can be used to enhance and circulate the providers to increase their quality of their healthcare services. So this feedback is also part of our payment models that we use. We call it, especially in primary care capitation, which we call it pay for performance capitation or KBK or KBK. Also, nowadays for hospital, we are piloting the pay for performance model, a special for hospital known as hospital-based value payment. And right now it is in piloting phase. Thus, for the organization internal requirements, we have developed a dashboard for visualization, advanced self-service analytics for all employees to increase all employees' capability towards a data-driven organization. And also we develop artificial intelligence. For example, right now, mostly we use it to accelerate the claim verification business process. Next slide, please. Next slide, please. Yeah, okay. This is our use case to show you how we use data to deliver insight and improvement from healthcare providers. So as I mentioned before, the pay for performance capitation or KBK is basically a commitment-based capitation that aims to measure the commitment of primary care providers to deliver primary care services comprehensively and according to required standards. So we have implemented these programs since 2015 with the hope that all primary care can improve their services to our participants. Based on the data we process on the big data systems, insights will be provided for service improvement by primary care. These programs aim to improve the quality of service following the competence of primary care optimally. Basically, there are three indicators which we use to measure the performance of primary care. Those three indicators are, first one is contact rate, second one is control clinical outcome, especially for disease management program members. Basically, this is our members with diabetes mellitus and hypertension disease. And the third one is a non-specialist referral ratio. Non-specialist referral ratio means that this is the diagnosis that the primary care refer to the hospital, which basically they can solve it, or basically are in the 144 diagnoses that should be treated in primary care. The graph on the right illustrates the result of pay performance program implementation. So you can see the result on the right side of the slide. This is the result for the contact rate indicator, the first indicators. So we can see that the contact rate indicates, basically the contact rate indicates the level of accessibility and utilization at primary care health providers by unique participant per month. It's including both inside and out activity inside and outside the healthcare facility, the primary care healthcare facility. The calculation is automatically counted by system, both from the system at the primary care or the teleconsultant via GKI Mobile. The implementation of teleconsultation started since April 2020. The utilization increases because we record every contact on the teleconsultation and calculated it as a contact rate result from the primary care in order to reach their target indicators. The green line represents the implementation of the pay performance program, which shows an increasing trend. In contrast, the silver line describes the health facility that have not implemented the pay performance program, where contact does not increase. So you can see the significant difference between the healthcare providers who implements the pay performance or join the pay performance program and the health facility who doesn't join the program. So next slide, please. So in this slide, I want to show you the result from the second indicators and the third indicators. So on the left side, we can see, and this is the result from the control from the indicator number, the second indicators, which is a control clinical outcome for disease management members. So we can see the number of control disease management program members are the participant with a diagnosis of diabetes or hypertension who are registered as disease management program members with fasting blood sugar levels for diabetes patient or blood pressure for control hypertension patient that follow the standards set by professional organizations. So the disease management program members only eligible based on their registrations at the primary care and have those diagnoses as the requirement. So you can see that the green lines, which represents the result of clinical outcome from DMP members, is significantly higher than the clinical outcome from non-disease management program members. So you can see the big difference there. Also, you can see that for the third indicators, which is on the chart in the right side, it illustrates the non-specialist referral ratio indicators. The ratio of non-specialist outpatient referrals indicates the optimal coordination and cooperation between primary care and referral health facility at an advanced level. The referral system is implemented according to medical indication and the competence of primary care. So you can see that healthcare facility who join this pay performance program have a lower non-specialistic referral ratio than the ones or the healthcare facility who didn't join this program. So basically, they refer less than the one that not joined the program. So, move on to the next slide, please. Okay, so from the description that I've shown, clearly indicate that to create a data-driven healthcare, we must ensure that IT must play 3 key roles, which are: first, IT should act or should play IT first role is as an enabler. As an enabler, we believe that IT will provide data and information that initiate and accelerate digital information in organizations. also improve the business process and enhance innovation, as in our case, such as integrated digital solution queuing system or implement biometric facial recognitions. The second role is in IT as a driver. As a driver, data insight will drive the business to achieve the business goals and delivering new insights and new ways to deliver value, such as data insight from big data analysis. And the last role is accelerators. As an accelerator, it will adopt new accelerating patterns to maintain digital business, to deliver digital product, and increase customer experience, such as mobile solution platforms. All of those key actions will create the data-driven healthcare, which produce an integrated product, so we can deliver the best experience for patients in effective and efficient ways. So next slide, please. So I think this is my last slide. I want to mention the lesson learned as our organization when we implementing data-driven for internal organization as well as for surrounding stakeholders. First lesson is that digital transformation and integration of among several business processes across system of stakeholders will provide significant benefits for administrative and public services. It will also increase and speed up the process to increase convenience. Second lesson that we learned, that data-driven management in healthcare system has become a strategic choice in achieving sustainable growth to face the uncertainty futures, and then meeting the challenges for global competition, and explore the potential innovation for the future based on data-driven fact. And the last, it's with a big data that creates from transaction. We also develop an artificial intelligence or big data analytic that could reshape the healthcare system with greater performance, especially in productivity that help operator by a machine, efficiency of business process, and the quality of healthcare services. And also, please don't forget the most important thing, that the data security governance framework must be fully implemented throughout every business process. So, next slide, please. Yeah, thank you very much for your time and attention. And I would also like to learn from other colleagues here as well in order to improve our JKN program in the future. Before I close my presentation, allow me to deliver Indonesian fun play words known as pantun. Walking around in Gangnam Street with a new sneakers on my feet. If you want to look what people need, look at the data and you will find it. Thank you. Kamsahamnida. Wassalamualaikum warahmatullahi wabarakatuh.
있습니다. 오늘 저는 저희 공단의 소개를 드리고 또 한국의 건강보험 관행에 대해서 소개를 을 중심으로 저희 건강보험 체계에 대해서 소개를 드리겠습니다. 한국의 건강보험 체계는 힘이 있다고 할 수 있습니다. 그 이유는 을 증진하고 있지만 보험료를 소득이나 개인의 역량에 따라서 차등 납부하고 있기 때문입니다. 하지만 반면에 제공이 되고 있습니다.
내가 그럼 얘기를 할까? Alright, I heard that
네, 방금
I was told that there's a like technical difficulties.
들어보니 지금 인도네시아 측에 기술적인 문제가 있다고 합니다. 그래서 잠시 발표를 중단하도록 하겠습니다. 기술적 문제가 해결이 되면 다시 발표를 재개하도록 하겠습니다.
처음부터 해주실 수 있나요?
다시 하라고?
아니, 아예 처음은 아니고요. 어디까지 끝내셨나요, 혹시?
나는 뭐 별로 그런 거 따지지 않고 했는데. 그냥 얘기하면 될 것 같아.
While in the meantime, so during this, so you after this presentation, we
네,
will
발표가
go into
끝나면
the Q&A
질의응답과 토론
So Korean
세션이 마련되어
panelists
있습니다.
should prepare
한국 패널리스트 여러분께서는 최소한 질문을 하나 이상은 각 발표자를 위해서 준비를 해주시길 바랍니다. 훌륭한 질문 기대하도록 하겠습니다.
So should I start? Okay.
네, 그럼 시작할까요?
Alright.
네.
Now everything's going to be okay.
네, 다 문제가 해결이 된 걸로 알고 발표를 재개하도록 하겠습니다.
The part that I just started before. Well,
입니다.
Korea's health insurance.
한국의
universal health
건강보험은
coverage for the first time in 12 years.
12년 만에
After the
UHC를
pilot implementation of
달성했습니다.
regional medical insurance,
지역 의료보험을 시범 사업으로 저희가 진행을 했었는데요. 농어촌 지역 관련해서 1988년에 진행을 했고 또 이것이 1989년에 도시 지역으로 확대되었습니다. 이후 단계적으로 저희가 통합 과정을 거치면서 성공적으로 UHC를 1989년, 2000년 초에 달성했습니다. 2000년에는 단일 보험자 시스템으로 전환을 했습니다. 그 결과 저희 공단이 설립되었습니다. 그 외에도 노인 장기 요양 보험 역시 2008년에 시행이 되었습니다. 5대 사회보험료 통합 징수가 2012년경에 이루어졌습니다. 2018년부터는 문케어 체계가 출범하게 되었는데요. 여기에는 사회보험 커버리지 확대가 포함이 되어 있고 이를 통해서 더 많은 급여를 국민들에게 제공하기 위한 노력이 수반되었습니다. 지금 보시는 것은 저희 공단의 거버넌스 구조입니다. 가운데 보시면 단일 보험자인 공단이 있고요. 피보험자와 또 의료기관들이 있습니다. 보건복지부가 감독자 역할을 하고 있습니다. 다음 슬라이드요. 다음으로 저희 공단 특징입니다. 저희는 전 국민 건강보험 체계를 위해서 노력하고 있고요.
뭐야, 왜 자꾸 그래?
You're checking English channel.
네, 지금 영어 채널 확인하겠습니다.
Do you hear English and Korean?
네,
together?
영어, 한국어 같이 들리시나요?
I'm sorry for the interpretation. 한국말로 테스트하겠습니다.
I'm going to do a test in Korean, and this is simultaneous interpretation being provided.
We're gonna use English first. If it sounds
네, 한국어로
Goes
마이크
okay.
테스트 하겠습니다. 잘 들리시는지
checking test.
확인 부탁드립니다.
I'm sorry for the. Okay. For the system error, we're gonna. I'm sorry. We're gonna use in English. Okay. We'll resume our presentation.
네, 그럼 발표를 재개하도록 하겠습니다.
아니 이게 잠깐만. 영어로 하는 걸로 하겠습니다. Sorry for the little bit of pending.
네.
There was a little bit of technical difficulties.
행사가 지연돼서 양해 부탁드립니다. 지금 통역 기능을 사용하는 데 있어서 기술적인 문제가 있었던 것 같습니다. 그래서 영어로 발표를 진행하도록 하겠습니다.
National Health Insurance Service is a single insurer.
네, 저희 공단이 단일 보험자고요.
Korea's case is a little bit unique.
한국은 조금 특이한 사례라고 할 수 있습니다.
94% of healthcare institutions are from the private
의료기관의 94%가 민영 의료기관입니다.
It's actually Korea's homework as well. It's a challenging.
이는 한국이 앞으로 풀어나가야 할 과제라고도 할 수 있습니다. 저희는 국립 의료 서비스 기관을 앞으로 확대해야 할 과제를 안고 있습니다. 민영 기관들이 지배하고 있는 구조이기 때문입니다. 다음으로 한국에서는 의료 서비스에 대한 접근성이 굉장히 높습니다. 길을 걷다가 몸이 좋지 않으면 금방이라도 병원에 방문을 할 수가 있습니다. 그리고 전 국민이 건강보험에 가입이 되어 있기 때문에 접근성이 굉장히 높다고 할 수 있습니다. 다음으로 포괄적인 급여가 제공되고 있습니다. 커버리지가 약 63% 정도 됩니다. 다른 OECD 회원국에 비해서 한국의 의료비 지출은 상당히 낮습니다. GDP의 8.1%인데요. OECD 평균은 8.8% 정도입니다. 미국이 16.9%, 독일이 11%입니다. 한국이 이 의료비에 있어서는 GDP와 비교해서 의료비에 있어서는 이 국가들보다 더 낮은 수준을 달성한 바 있습니다. 가입자 커버리지를 보겠습니다. 전 국민이 가입해 있다고 해도 과언이 아닙니다.
we are providing
그리고 사회
medical aid,
취약계층
which is
같은
2.8%
경우에는
of
저희가
the
의료
population.
급여를
So
제공하고 있는데요.
technically,
의료 급여
basically,
수급권자가
all
전 국민의
people are covered
2.8%입니다.
by the some of the
기술적으로
social
보았을
security
때 이
insurances.
사회보장보험을
The source of
통해서
finance
전
is
국민이 가입이 되어
86%
있다고 해도
is from the
무방합니다.
insured
다음으로 재원을
contributions. So
보시겠습니다.
that, one of the good things
먼저 보험료로 약
Korea's
58조가 마련이 되어
system is
있는데요.
it's
한국
not,
체계의 좋은 점 중 하나는
heavily dependent upon the situation, economic situation.
경제, 국가의
That's the,
경제
which is
상황에 크게
independent from the economic,
영향을 받지
situation. That's
않는다는
one of the
것입니다.
good
상당히
sustainability
경제
of
상황과
the system of
독립되어
national
있기
housing
때문에
insurance in Korea. Next slide, please.
이것이 한국의 장점 중 하나라고
This is the
하겠습니다.
comparing the how long would take for the achieving universal
보시는
health coverage
장표는
of all the
UHC
countries.
달성까지
The first
걸린
one is Germany.
기간을 국가별로
It took,
나타낸 것입니다.
127 years
먼저
for the
독일은
UHC.
127년
Israel
걸렸고요.
is 84
다음으로
years.
이스라엘은 84년
Japan
걸렸습니다.
has 36
일본은
years.
36년,
Korea is 12
한국은
years.
12년
I know
걸렸습니다.
BPJS is also very short.
BPJS 역시 상당히 단기간에 UHC를 달성한 것으로 저는 알고 있습니다.
Next slide, please. One of the key factors of the UHC achievement, we can say,
UHC 달성을 위해서 중요한 요인이 두 가지가 있습니다. 첫 번째는 사회 경제적 지위인데요. 한국 경제는 매우 급속도로 성장했습니다. 정부 주도의 경제 개발 계획이 수립이 되었고 그로 인한 경제 성장 덕분에 저희가 지속 가능한 재원을 확보해서 국민에 대한 급여를 확대할 수 있었습니다. 또 국민 역시 이 국가 건강보험에 대한 염원을 가지고 있었고 또 이를 시민단체나 노조에서 강력하게 개혁해달라고 요구를 한 바 있습니다. 다음으로 강력한 정치적 의지에 기반한 전략적 정책이 수립된 것 역시 굉장히 중요한 요인이었다 하겠습니다. 이것이 성과인데요. 지금 한국의 수명은 평균 수명은 82.7세입니다. OECD 평균은 80.7세입니다. 결국 한국의 경우가 OECD 평균보다 더 높다고 할 수 있고 그 우측에 보시면 영아 사망률인데요. 1000명당 사망 건수를 나타낸 것입니다. 2017년 기준이지만 한국은 사망률이 2.7명밖에 되지 않습니다. OECD 평균은 3.5명이기 때문에 OECD 평균보다도 훨씬 낮은 수준이라고 할 수 있습니다. 다시 말해서 이 건강보험과 또 한국의 정부 정책 덕분에 한국은 매우 높은 수준의 의료적 성과를 OECD 회원국 평균에 비해서 달성했다고 할 수 있습니다. 다음으로 의료보건 자원 확대에 대해서 말씀드리겠습니다. 지금 의료기관의 수는 5배 이상으로 증가했고 병상은 13.7배 이상 증가했습니다. 인적 자원은 거의 10배 증가했습니다. UHC 달성에 함에 있어서 의료기관이나 시설 그리고 자원의 품질 역시 굉장히 중요하다는 것을 강증해주는 사례라고 생각합니다. 이를 통해서 저희가 국민으로부터 큰 만족도를 달성할 수 있을 것입니다. 다음으로 보험료 관련해서 말씀을 드리겠습니다. 지금 직장 가입자와 지역 가입자로 나뉘는데요. 직장 가입자 같은 경우에는 직원과 고용주가 50대 50으로 보험료를 납부합니다. 전 20년 기준으로 보험료율은 6.67%였습니다. 다시 말해서 만약 여러분께서 한 기관에서 직원으로 있다면 소득에서 약 3.3%를 보험료로 납부를 한다는 얘기입니다. 지역 가입자 같은 경우는 조금 다르게 산정이 됩니다. 개인의 소득이나 재산 그리고 보유하고 있는 차량을 기반으로 환산된 점수에 따라서 보험료가 계산이 됩니다.
It's a little bit complicated. But so the self-employed insured versus employee insured are the two main roles in Korea for the contribution collection. Next slide, please. Yeah, I just explained and just skip it. Just next slide, please. mostly, 97% are benefits in kind. So diagnosis, test, treatment, surgery, rehabilitation, drugs and medical materials, and those are the benefits in kind by National Health Insurance Service. Next slide, please. Now, I know the Indonesia has a big interest and agenda regarding the data-driven national health insurance, which BPJS. And the slide that I'm going to introduce here is the overall NHIS ICT system architecture. We have a headquarters and we have a local branches, and every resources are centralized. We have a system servers, more than 800 server, and databases, 78 databases. And you can see the database tables, number of tables are right now almost 200,000 this year, which is a huge, you can think about 200,000 database tables located in the all National Health Insurance Service inside. And more than 400 terabytes of data we are managing. And all the data is also with the external organization linked with the more than 36 organizations. All right, next slide, please. And I think Tony was also mentioning the importance of the information security of the National Health Insurance. That's because he's also in Korea. All the data we are right now doing, that's by the national citizen information, personal data, very critical to the nationwide, the impact. That's why we have a very strong information protection system, such as like you can see the slide from the left-hand side. If the hacker, the intruders would like to tap into the NHI system, they came across more than 7 layers of the protection: DDoS protection system, intrusion protection system we call IPS, and first intrusion blocking is from the firewall, and DMG configuration from the web traffics, and also second intrusion detection blocking system, and we have an intrusion detection system as well. And then we can approaching to web division. One of the strongest information protection systems that the NHI is doing this. So I know the Indonesia would like to find the data-driven the national health insurance, information security experiences, and our best practices. They can be one of the good agenda for the collaboration between the two institutions. Next slide, please. This is the IST data linkages out of the National Health Insurance Service. The mostly, Korea's the public organizations are under government dedicated networks, so that the government dedicated networks, they can transfer files and mobilize overall the types of data very easily and very securely. Next slides. And I told you that overall Korea's system, we are collecting 4 insurance contributions from the citizens. That's why we have a ESB, Enterprise Service Bus, and Enterprise Service Architecture, and linking to National Pension Service and other social security institutions as well. Next slide, please. And the data-driven big data is also very critical elements of Korea as well. The thing is, big data has the very powerful for policy making as well as the practices of National Health Insurance Service. For instance, that's the actually National Health Alarm Service, that if there's like the flu or any kind of the like infant pneumonia and eye diseases, and there are other food poisoning, asthma, and many other, the contagious, diseases, then it can we have attention, and we have a caution, and we have a warning, and we have a danger, and we have a 4 stages of alarming service for diseases in 250 regions, which is we are using by the big data system. Next slide. And the My Health Bank is more like customized the health system that we can provide a more customized health practices treatment for the people as well. So if you have like diabetes, or if you have a high blood pressure, then you can have the more like other treatments in addition to the medication in advance. That it can increase longevity of the people, as well as the guaranteeing the better life, especially in the elder people. Next slides. In national where financial management has, I just mentioned, but at this point, we have a K health strategy and team, and that team is doing with the ASEAN countries, like 10 countries, including Indonesia this year, to try to provide more sustainable way of financial management of an institution based on data governance, current practices, and other things. So if you're also interested in the financial sustainable management, then that's also second topic that we can start the collaboration as well for the next phase of the MOU. Next slides. And also introducing the long-term care insurance, and we have not only in Korea but also Indonesia, we have demographic challenges, aged population increase, fertility rate is also decreasing, healthcare expenditure is increasing, and financial revenue is also decreasing. So many of the financial burdens is coming, which means not only Korea but also Indonesia is also, we are into the more like super aging society. That's the aged population spend about 40% of total healthcare expenditure is the fact right now in Korea. So that we should be more considerate, and we should be more focusing on the elderly people's healthcare, especially in the super aging society. Next slide, please. Actually, national health insurance law and the long-term care insurance law is different. We enacted as a separate law. That's because we think long-term care insurance is more into the different law. And we were thinking that the long-term care the part will be increasing, maybe especially in the super aging paradigms. And it's a state subsidization and also single insurer system operated by the National Health Insurance Service. And the payment focus on the older people with also disabilities. Next slides. Next slides. Due to time, limits, we have a little bit the over time. So next slides. Next slides. So benefits are really like 3 types: benefits for home care service, and also we have an institutional care benefit, and also we have a care allowances for special cases. Next. The final thing that I'm going to introduce today is the next slide, the COVID resilience by the National Health Insurance Service. Next. You can see the left-hand side that the National Health Insurance Service, you see there's 2 cases. One is the right-hand side is the United States, and the left-hand side is Korea. If you're in United States and we are without subscription of any kind of the health insurance service, then you should pay more than $40,000. But if you're in Korea, you're paying nothing. So that is why the people in Korea are not afraid of getting the test and getting the treatment of by the hospitals. So that after the COVID-19, I know we are in the very critical situation, but people's awareness and the trust to the National Health Insurance Service, it's more than 80% of the people are affirmative, positive attitude toward the National Health Insurance Service. And also the second thing that I'm going to introduce here is we are using the big data for the stabilization of the healthcare, the infrastructure. That is, if one infected, the patients already have some of the diseases such as like high blood pressure, diabetics, and other types of the disease, then they should moving to negative pressure room in the hospital. But if one infected patient is not that severe symptoms, then they are moving to the local community treatment center, which is, if everyone is moving to the hospital in the negative pressurized room, then the medical infrastructure of Korea will be collapsed soon. But we are managing those, segmenting the infected patients from severity to lower level of the symptom. That's also by the big data usages of National Health Insurance Service. Thanks. And other, we provided some of the good things to the nationwide COVID-19 resilience of Korea. And my final remarks of the today's presentation is data-driven, ICT governance, and also sustainable financial management. Those part can be the collaboration and cooperation in the second waves of MOU between BPJS and National Health Insurance Service of the Republic of Korea. So I know, in between there's some of the technical difficulties of the translation and the communication. Please, accept that this is the international conference by using online solution. And we have more time to Q&A and discussion. If you have any questions and if you have any ideas for the collaboration, cooperation for the future endeavor, just like the topics of today's conference, I'll be happy to be with you. Thank you.
Okay, thank you very much, Dr. Kang. So now we are in Q&A session. So we have about 20 minutes for the Q&A session. So first, Korean panel can ask question on the Indonesian presentation. And next, Indonesian participants will question on the Dr. Kang's presentation. So anyone who has a question or a comment, please give us your question.
네, 제가 먼저 말씀드리겠습니다. 저는 가천대학교에 근무하는 김덕호라고 합니다.
I was very impressed by the data-driven healthcare system in Indonesia and your performance. I'm wondering, so all the data between the primary care and the secondary and the tertiary. So EMR, is that the EMR data record or is that the processed data separately? So I'm wondering. And my second question is, FFS, the biggest problem of the FFS is overuse. How do you control the overuse case in Indonesia using big data? Could you elaborate about that? Mr. Doni Hendrawan?
Oh yeah, sorry.
Are you hearing us?
Okay, okay. But can you please repeat the first question because I hear it clearly. The first question. Can you please repeat it?
So you have a lot of data going on between the primary care and secondary and tertiaries. So is that the EMR, the record itself, or is that the processed data separately?
Okay. Thank you for the very interesting question. First of all, the data that runs between primary and hospital is basically we can see the AMR data, yeah. I mean medical record data, but not all medical record are recording in our systems. But basically, it is a very important one, such as patients' demography, and then a specific measurements such as maybe diagnosis, and then treatment, symptoms, and other risk factors such as maybe obesity or something like that. So all this data will run and will be transferred between the primary and secondary facility. So something like that. The second one is how can we control the overuse of, but first of all, we don't use fee for service both in primary care sectors and in the hospital sectors. As I mentioned before, in primary care sectors, we use the capitation, and in the hospital sector, we use DRG or inner CBGs. But we still monitoring the utilization from the patient through the big data. So as I also mentioned before, that we have internal dashboard which can be monitoring or can be used or utilized by our employees, so they can extract the data from that and will analyze the data, whether to see, for example, the trends, whether maybe this month the visiting or the use of maybe the use of CT scan is much more higher than last month, something like that. So we keep on tracking that, and also in the systems we also use some AI to help us to prevent fraud or abuse. For example, when we in the verification system from hospital billing, we put AI so it can detect outliers maybe, or also maybe unusual behavior from the providers or unusual claim. So it will soon warnings the verificators, and then the verificators will check and try to try to see what's really happened. So I think that's my answer. Thank you. I hope it's answer your question.
Yeah, you could.
네, 좋은 답변 감사합니다.
Thank you for the great answer.
Thank you. Thank you very much.
So I have additional question. So in summary, among the EMR data, you processed some data for using the big data. So when you make the processed data, specification is designated by BPJS, or when the hospital enter this data, or is automatically entered? So I'm wondering. And you also said about the billing. You are using the DRG for the billing system, payment system. So the DRG is for the inpatients. How about the outpatients? You are using the capitation per dime. And do you pay the outpatient using the capitation per dime? And when you do that, so the data and all the medical records are described in detail in the data, or it's just data about the visiting, the simple visiting?
Okay, thank you again for the very interesting question, I think. And first question, I will try to answer the first question, whether hospital enter the data or it can do automatically. Basically, the data the hospital key in the data into the systems due to the claim process, and then we subtract the data from the claim process, and we can have a big data from that. So it is just like that. So still they have to enter the data into the system, and then for the outpatients sectors, we also implement the RG system. We not implement capitation. Capitation is only for primary cares, but for hospital, for outpatient in hospital, we use DRG methods. So, and then I'm sorry, can you repeat the last question? I'm sorry.
My second question was that about the outpatient. So outpatient is per dime. So when you do the per dime for the outpatient, all the medical record is notified, or just the visiting record is notified?
Is it in hospital or primary? Because like I mentioned before, in outpatient in hospital, we still implemented DRG as the payment system, not per diem. Per diem is only for inpatient in primary cares. So basically, in primary care, there are some health facility that can treat patient inpatient, just for the simple diseases like maybe gastroenteritis, or maybe just like simple disease like that. So they can still make those patient or treat this patient in inpatient. And in primary care, we pay them by per diem, but in hospital we pay them with DRG. Is it my answer?
네. Thank you very much.
Okay, thank you.
Thank you. Thank you very much.
Due to time limit, so Indonesian participants will give Dr. Kang's presentation. So in the computer, Dr. Kang, in the computer there are two questions for you.
So, okay. In my QA and square answer. Okay. What? But I cannot see it. Where is it? Sorry.
This is time for the Indonesian panelists to ask a question to Korean presenter. So the Korean, we already saw the question, so Korea will answer the question. So your question was that from the NHI scheme in Korea, the insured have a contribution as a co-payment in obtaining the health service benefits. What is the form? I'm sorry. So the way of the building the loyalty of the customer. Sorry. So that was the question from the Indonesia panelists. So anyone can answer to the questions? So would you summarize the question again? So please
explain us more detail.
The person who asked the question, would you elaborate the question again? Because we could not understand your question perfectly.
Can I ask the question? Can I ask the questions?
your question?
Any questions from the Indonesian panelists?
Yes, can we ask a question? Hello? Can we ask a question? Yeah. Hello?
So please the question again.
Hello? Can we ask the questions?
Yes, you can ask the question now.
Yeah. So I think in Korea, if I'm not mistaken, the health providers, the hospitals and clinics are private. How many percent are private? And do you have difficulties to control the privates? Because like in Indonesia, now the private is growing, especially the hospital is around 60%. And in fact, actually, if more public hospitals is much easier, but I'm not sure in the experience of the Korea, because if I'm not mistaken, most of the health providers in Korea are private, like hospitals and clinics. And is that any problem? Is it difficult or easy to control the private providers, private hospitals, and private clinics? Thank you.
So we provide service based on the private healthcare institutions. So BPJS and Korea NHIS shared a lot of knowledges together, and we introduced the policies in advance fully before. So rather than asking the question about the policy itself, today's purpose of the seminar is about how we can collaborate and cooperate in detail, specifically, and what kind of project we can do between the NHIS and the BPJS. That's the focus of today's webinar. So let me tell you the answer to the question first, and then I will ask the question back to you. So the Korea is more private healthcare institution oriented. Under the law, Korean law, all the institutions can participate as aid providers. So under the framework of the law, they can provide the healthcare service, and we can manage and control them. However, the Indonesia, you have all the public institutions providers, so maybe it is difficult for draw the participation of the private healthcare agencies. So in order to manage all the provider, you have to have a law, the basic laws and regulation first. And for more specific information, we will reply back to you through the emails. I have one question to you. So far, the BPJS and NHIS, we had the co-development project and the capacity building together so far. In the future, for the expansion of the service for the vulnerable classes, What kind of collaboration do you want? Or what kind of support can we give to you? So please let us know your idea about that.
To Indonesian participants, anyone can answer to the Korean panel's question
Yes, of course.
on the further collaboration between NHIS and the BPJS.
Yes, I think there are many issues, topics that we can talk as the project in the future. For example, that of course management information system, how to make automatization, and not only for registration, but also virtual claim, as well as analyzing the claims and analyzing the data. And we can not only analyze but also making evidence-based policy, as well as then we can publish in the journals. That is the first one. The second, I think the capacity building of human resources. I think the capacity building is one of the important aspect of the future projects. And then, of course, the system, how we can detect automatically and sensitively about the fraud, and how to reduce the fraud and to detect, then to treat the fraud.
Okay, so time was over, so we have to finish the first session now. So in the meantime, many Indonesian participants left several questions on the computer. So NHS step, okay, will answer to you by email or in other way. So final
조금만요, 제가.
yeah, comment or final message from Dr. Kang. So after his
묵티 그 교수님 거니까.
message, at his comment, we will finish this session. Thank you for all your participation. Thank you.
Well, hello, Professor Mukti. How
Yeah.
are you?
Fine. Thank you, Ben. Thank you.
Yeah, we've been, working on TC Health and ISA, and I know you are very fervent, the chairman of the TC Health of ISA, and I appreciate your endeavor and effort for the overall working in the TC Health, and it's very fruitful and meaningful for ISA member states as well.
Thank you, Ben, for the very good in working together. Thank you.
Sure. Back to your question. I think that's the most important thing in the today's workshop. What areas that we are going to cooperate between NHIS and BPJSK. For instance, I was seeing that many of the today's the presentation, it's toward a data-driven initiative, so that I think you have a really right track for the increasing, especially for the informal groups, increasing the sustainability of the financial management, as well as the eligibility, collection, and all those things are very important, especially for the informal group as well. What my suggestion, one of my suggestions today, we can the streamlining more into more details, crystallizing the details. But one thing is actually it's process-wise. The process is very important for transforming into digital, so that business process of collection, eligibility, and also setting the benefit level, all are based on the process. So that once the process is analyzed and that's why we call BPR, business process reengineering. And then after BPL, you can go into information systems planning, ISP. And the basis of that is the identification of the current practices and the processes. So, next, one of the agenda that we are doing in HIS, with is working with the ASEAN Secretariat. Indonesia is a part of ASEAN member states. So that what we are thinking
In
is,
fact, the Secretariat ASEAN office is in Jakarta, located in Jakarta, the Secretariat ASEAN office.
so identification of the process of BPJSK, especially the informal group, as a consulting, and we are doing that into this year and the next year. So that I think that's one of the topic that we can start with, the identification of the processes and practices of the Indonesians, especially informal group. And then we can moving into more like the process, the re-engineering, and then financial management system is the target that we are thinking of to the ASEAN member states. So that's what we do in the K-Health project in the NHIS. That might be one of the things that we can start the collaboration. The second thing is big data. How we can utilize the big data is from the data governance, which means what data we can collect, what data we can have a standard format, and how we can move the data into different organizations by using web service or other protocols. That is the part that we can think of. That's a part of data governance. So, can I go on? So I would suggest the data governance things, as well as the identifying the current status of the business process of the especially informal group in Indonesia. Maybe that can be the two candidates that we can streamlining. So more detailed, the comments and by our steps and the BPJS steps for the actual the collaboration area. But that's the comments to Professor Mukti as well, and also partly for Doni. Thank you.
Thank you. I think this will be very important topic, I think.
네. Thank you very much. Thank you very much. All the Indonesian panelists and the Korean panelists, I'd like to send my gratitude. So with this, we will wrap up the first session. Thank you very much.
저희 한국 여기 참석하신 분들 저희가 전체적으로 기념 촬영을 한번 하도록 하겠습니다. 다 앞으로 나오셔서 사진 촬영에 협조해 주시기 바랍니다.